enthusiasm for sustaining our ASICON conference. So thank you so much, and also, good morning to many of your luminaries who are all here, and including Dr. Ribari. I might be indirectly attacking you, so please don't get offended. So now the topic given to me is, so what India will lose if we don't treat everyone? Already we are running 3 years late, right? So a couple of weeks back, it's been recommended to initiate treatment at 500. From WHO guidelines, me being part of the guidelines, we recommended in the year 2013, many programs, adapted that, but we are already running 3 years. I'm going to tell you, and I don't know how long it will take again. Dr. Ribari many times said soon, soon, soon. We need to define the definition of soon for India. So we need to, I'm going to here say that what the major consequence, India will be, paying over a period of time if you're not going to treat everybody. You saw this again and again. I'm sure you would have seen yesterday and today again and again. So this is a new WHO recommendations, and 2015 launched, and 2016 became a recommendation of UN declaration. So today, we have to treat everybody. If you don't treat, it's a malpractice. So we always have to go either follow WHO guideline or you should go up. If you say that we are not going to follow at that standard, I think we may have to pay a lot of consequences. Why I'm talking about this is, so I participated in this process from the scientific perspective. The first thing is, I like to tell you that, so what's the study, which make these changes to happen, and as a result, what are the public health consequences if you're not going to adapt, all those will happen. So 5 years back, our group published this HP10-052 study, again in India, Chennai, Vyarjikar, and Nari Pune heavily participated in this trial, where we showed 96% reduction in HIV transmission if you put people on treatment. You're able to see that in their serodiscordant couples. So we continued this study, and what the changes we found is we wanted to prove the durability of this prevention effect by these antiretroviral drugs to those serodiscordant couples. So after 2011, Data Safety Monitoring Board asked us to put everyone on antiretroviral treatment. You all know that in HP10-052 we had 2 arms. One arm received immediate therapy, another one delayed up to 350 or whatever the country guidelines. Some countries adapted 250. So after this 2011, the interim results, everyone have been offered treatment. So what we found now the paper is now again we published in the New England Journal of Medicine a month back. What we have shown is consistently more than 90% effect. This is a great effect. We have a durability in prevention, sexual prevention of HIV following this antiretroviral treatment. But again, others in this session stressed about the importance of adherence and the continuity of the treatment. That's again is very important when you talk about prevention in the context of ART. So if you ask me a question, who are those transmitted? We found 8 linked transmission in HP10-052. Out of those, 4 infections likely occurred either before or soon after the index partner started on ART. That means they're not on sufficient amount of time, so on ART to suppress the virus, and 4 infections occurred after the index partner failed ART. This very clearly shows that if there is some virus, they can transmit HIV. So this is very clear. So that's the major consequences which I'm trying to say. So this study, HP10-052, very clearly a landmark study, after 10 years of conducting this trial, very clearly we showed ART is highly effective in preventing sexual transmission of HIV. So what, the consequence for India? So this is our latest figures, which you all have seen. So now given by UNAIDS and NACO, we have got 2.1 million people being infected with HIV, estimated. And out of those, which we all believe, more than 90% to sexual transmission. So when we have a study data showing that ART prevents sexual transmission of HIV, if we don't implement, in a country where we got 90% transmission through sexual route, how we are going to contain this HIV epidemic? Just sit in a corner of a room and calculate yourself how much transmission will be happening every day if you're not going to put people on treatment. Again, our data shows out of the 2.1 million estimated, in India, only around 43% still receiving treatment. So again, the numbers will swell up if you're not going to put the proper guidelines of treat all. I think this has been developed based on the threshold of 500. This very clearly shows that if you're not treating, exponentially, the HIV transmission continuously swell. We may talk about other ways of prevention. So this is, again, data where it shows where we have mapped all the various interventions in one slide. If you have a vaccine, again, we don't have a vaccine, it is 31% efficacy. If you treat STIs, which we all did for years and years, which still continuously do, but only 42% effect in reducing transmission, and PrEP in MSM almost around 50% now going up, and PrEP in heterosexual 63%, PrEP in serodiscordant couples 73%. And if you put on ART, the transmission is 96%. So in a country like India, sexual transmission is a majority mode of transmission. If you're not putting on ART, and if you have been keep looking at other mode of intervention, you're not going to prevent transmission in our country. It may swell beyond 2 million soon. So you may ask that, so this is for a public health benefit. Now, why should you harm someone putting on treatment at a higher CD4 where they don't need a treatment? You know, you may ask this question, so what's the individual benefit? That was very clearly shown by START study. I'm not going to the detail. I think last year I presented the START study results to the audience here at the ASICON. So START study, again, it was been carried out in 120 centers. In India, Chennai, we participated. We are the second highest enrolling site across the globe. And where we have two arms. One received immediate treatment when the CD4 is more than 500, and another one arm, we waited up to 350, or if they develop any one of those age-defining illness. I'm not going to the details of the START study, but just to show that if you're not going to put treatment to everybody, what will be the consequence? So in this study, very clearly we have shown, and we are able to prevent both serious AIDS events and as well as non-AIDS complications. So if you see this, if it's an immediate effect, there are 14 individuals, and in the deferred arm, 50. And if you look into these non-AIDS complication, 29 versus 47. This very clearly shows that by putting on treatment, there is enormous individual benefit. Again, if you ask me what are those individual enormous benefit, TB, a country like India, sitting in Mumbai, where TB epidemic, if you don't put on ART, you're not going to prevent TB. You know, we talk about IPT, still not fully been implemented. I think it's a great opportunity, test everyone, put them on treatment, you're able to prevent TB. And lymphoma, in the developed world, where they have seen reduction in lymphoma if you start treatment early. And in sub-Saharan Africa, where Kaposi sarcoma is very high, where they're able to prevent by putting early on treatment, and also all the other opportunistic infections. What about non-AIDS complications? So in India, we are sitting as an epidemic of NCDs in the general population, where again, HIV will fuel that because of a lot of inflammation due to HIV. So now again, by putting on treatment, we are able to prevent non-AIDS cancers and cardiovascular disease and various other renal and liver. We are not able to see this on a long run because now everyone, in START studies on continuing on treatment. We are not delaying anyone because after the interim results, everyone on treatment. So even still, we are able to find that we are able to prevent various non-communicable diseases. So there is enormous individual benefit. It's not just a public health benefit. So in India, if you're not testing everyone and put them on the treatment immediately, we will lose a great opportunity of denying this public health benefit as well as individual benefit. There's no doubt in that. Science says. I'm not saying. They're following all these guidelines moving to treat all. So next step is now in the 2016 guidelines, we also have some of the new drugs like dolutegravir and also reducing the dosage of efavirenz 400. So you may ask a question, someone with 1,200 CD4, perfectly fine. When I put them on various efavirenz containing therapy, they have dizziness and they have a lot of other complications, how will I do that? So for these reasons, now we have other alternate drugs. Again, what is a good thing about alternate drug is, again, so this is a single trial, which is a study which compared between efavirenz and dolutegravir, where you can see the x-axis showing the duration of weeks on treatment, and y-axis is a proportion of patients who have got suppressed viral load. The green curve is patients who are on efavirenz containing therapy, and the lighter white color curve is patients who are on dolutegravir containing therapy. So this data very clearly shows that patients who are on dolutegravir, they got a higher virological suppression as compared to efavirenz containing therapy. And very importantly, particularly for India, if you're not going to adapt these newer guidance, and where if you see this, you are able to see this virological suppression very early on if you are on dolutegravir. I think this is very important, especially in a country like India, where we got a huge sexual transmission. If you're able to put people early on treatment with dolutegravir containing therapy, we'll be able to suppress this virus enormously, where we'll also have an enormous prevention benefit by suppressing the virus very early on as compared to efavirenz. This is something where I think India should move on as soon as possible. Any delay will have a huge penalty we'll be paying to our public and to the program. And also, in this single trial, also been shown that there is very little psychiatric events as compared to efavirenz, where we all see and in our clinic population. So today, if you put everyone on treatment, where you have enormous public health benefit, enormous individual benefit, and also adapting the newer drugs, will have a much super effect on this. Then program managers might ask you a question. Hey, it might cost so much money. Dr. Rivari, in one other slide, he said several crores rupees is going to cost India. So to answer this, we have done some modeling exercise. So this is a modeling exercise our group did in collaboration with the Harvard group on the HPT and O52 data. So what we did in this is we used HPT and O52 data, and also we saw the effectiveness, and also we had seen the various effects of ART on putting on treatment at higher CD4, as well as on the prevention effect. What we found is both in India and South Africa, putting treatment at a higher CD4 will be cost effective and as well as cost saving. So this is something where we cannot debate. This is something we have to sell to our program managers to get this for our population. Next thing I'm going into there is science. So today we are all talking about cure. A couple of days back you read about the news clipping from UK about a patient nearly been eradicated. Again, how this is possible? You all know that someone who is HIV positive today is not the question of viremia and in the blood, but also every day they are also been setting up reservoirs. So this is a curve which shows that someone who is being viremic, when you put them on antiretroviral treatment, the virus goes to an undetectable level. You're not going to eradicate from the blood, from any of the organs. You have been going to suppress in the blood, but still it's sequestrated into various organs. We call it as reservoirs, which is in the CSF, it's in the genital tissue, it's in the gut, and as a result, they can still multiplying there. So if you're not going to start treatment early, the reservoirs will start setting not here, from here. So that means you are allowing your patients to start setting up more and more reservoirs. So today, if you're not going to eradicate, what will happen is if you've got more reservoirs, there could be considerable residual viremia, which can lead to more chronic inflammation, which can also lead to a lot of other non-communicable diseases like cardiovascular, kidney disease, faster evolution of hepatitis and cancers. So today the way we, researchers are finding a cure is to identify all those reservoirs. If you are making a patient to set up more reservoirs, again, it will be very difficult when we have a real cure. So today, the primary question is, what is the full extent of latent pool? How do we eliminate it? So for that, the first quick answer should be start treatment early. If you don't do that, you'll not be able to eradicate one day, even if you have an eradication tool with you. So to answer this, at our center at VYRG Care, in collaboration with the University of Miami and with the grant support from NIH and as well as the ICMR, we started a very large project a couple of years back to understand the immune activation and reservoir size in Indian HIV-infected people who have started at a CD4 of 200, 350, 500, and more than 500. So again, this is a work in progress. I'll not be able to show the full data, but we just submitted to CROI. But I'd like to tell you that the initial results very clearly shows that if you're not going to start treatment early, especially in the Indian population, you'll have a lot of immune activation, which will cause more harm, and as well as the reservoir size will go up. And as a result, you'll have a lot of consequence, and also you'll deny a great opportunity of eradicating your HIV-infected patients. So if you don't start treatment, they'll have a huge reservoirs. You'll hear more on this at CROI if you're able to attend and if you have an opportunity to get accepted, and we'll be disseminating this soon. Next thing is, so how we are going to find these people? So till now, even in our ART centers, as well as private clinic, people who are coming are very sick. Either CD4 is 200, now it has gone to 350 or 400 median CD4. So how we are going to find everybody, 1,000 CD4 or 1,200 CD4 or soon after they are acquired HIV? So we did, again, a modeling exercise in collaboration with the NACO and the CPAC group in Harvard, where we used incidents from our NACO data and as well as the cost for HIV testing and counseling and linking to the care. So what we found in this model is, if you want to identify everyone who have been HIV positive in India, how we are going to do this? You have to do a voluntary HIV screening among our national population every 5 years, which will offer substantial clinical benefit and will be cost effective. And also annual screening will be cost effective among high-risk population, especially among injecting drug users, MSM and female sex workers, and in migrant population, and as well as in certain high-prevalent districts in Northeast India, and as well as in Andhra Pradesh. So this is something what we have been now done a model, and we have been negotiating with NACO, how we can effectively implement to find all these people, link them to the treatment so that we'll have both public health benefit, as well as individual benefit, and as well as a cost benefit, as well as scientific benefit. But concluding, why again we need to treat all? This definitely will prevent sexual transmission in India, which is a major mode of HIV transmission. No doubt it will prevent morbidity and mortality, especially tuberculosis and non-communicable diseases, and will be cost effective, any amount of models. This afternoon, I'll be talking to you on impact of WHO 2016 guideline on more cost-effective analysis. And very importantly, we'll also prevent loss to follow. Today, a lot of data coming up, especially from sub-Saharan Africa. If you test some, if you don't link them to care and put them on treatment, you will lose some, which will be very expensive, or they might be transmitting infection to more people, or they will come to be in a very sick and morbid condition with 5 or 10 CD4 or with pneumocystis pneumonia. It might be more expensive to treat. So again, by testing everyone and putting them on treatment very early will prevent loss to follow, will be cost effective. I think that's my last slide. Thank you very much and happy to take any questions.